Thanks, Cherry. CO, hello everyone, and welcome again. I'm Julie Seward. I lead the Native Oral Health Network. I'm the Oral Health Programs Manager at the Southern Plains Tribal Health Board, and I'm joined, thankfully, by two of some of the best epidemiologists around, Alex and Amanda. So glad they're here with me to present and talk about all of our collective work. I'm going to share my screen here and we will get started. Okay. So before we jump into our projects, I just want to set the stage just a little before we kind of get into into the nitty gritty. So the Native Oral Health Network, just want to just tell you a little bit about about who we are. It's a program that's housed at the Southern Plains Tribal Health Board, Oklahoma Tribal Epidemiology Center. And so SPTHB, that's what I'll call it from now on to save time. It is a nonprofit organization based here in Oklahoma City, Oklahoma. And so SPTHB was established in 1972 to provide a unified voice on tribal public health needs and policy for the 44 federally recognized tribes located in Oklahoma, Kansas, and Texas. So we exist to serve the tribes in our area. And so NOHN's mission is to build healthier Native communities by connecting oral health to overall health and wellness through peer support, collaboration, and community engagement. Since NOHN's inception, which was in the end of 2017, we've grown to roughly 200 members now nationwide, not just our service area, now nationwide. And we work with other area Indian health boards across the nation, other tribal epidemiology centers, other area IHS, Indian Health Service. I'm trying to do better about saying acronyms. Other Indian Health Service dental support centers across the nation, and other public health partners to advance oral health equity for the American Indian Alaska Native population. And so, like I mentioned earlier, we're going to talk about some of our recent projects and how we are really focusing on data discussions to increase American Indian Alaska Native representation. And so with that, for our first project, I'm going to hand it over to Alex and then Amanda.
Thank you. Yeah, so our first data report that we had published was the Indian Health Service Oklahoma City area oral health report. So this, the IHS OKC area we previously mentioned is located in Oklahoma, Kansas, and Texas. So the purpose of this report was to collect, analyze, and synthesize all of the current oral health data. We looked at American Indian Alaska Native populations in the IHS OKC area, as well as the IHS nationwide population, the Oklahoma State population, and also the US general population. We also wanted to provide all of the relevant data in one place in an easy to access format for our partners and for anyone else interested in advancing oral health equity among American Indian Alaska Natives. And we also wanted to initiate ongoing engagement process with stakeholders to align action with data. Data is very powerful, and you can do a lot with it, but you have to have some action with it. So the data in this report includes data from the Indian Health Service. IHS puts out these oral health surveys periodically. These are community and clinic-based surveys, and their populations include children ages 1 to 5, 6 to 9, and 13 to 15, as well as adults 35 and over. We also looked at the Centers for Disease Control and Prevention, using them to get data from the National Health and Nutrition Examination Survey for the US general population. We also had received data from the ADA for their dentist to population ratio for the state of Oklahoma and the US general population. And then some other sources include the National Institutes of Health, the Department of Health and Human Services, peer-reviewed articles, and we also collected data from the Southern Plains Tribal Health Board collected its own data on the dentist to patient ratio in the IHS OKC area, because that was not previously published anywhere. I'm going to hand it off to Amanda to talk more about the types of data included and the limitations.
Thanks, Alex. So as mentioned, we wanted to understand oral health outcomes among these three groups: IHS OKC area, IHS nationally, and then the general US population. And at first we wanted to make direct comparisons, but one of the biggest challenges we found was that even though we were collecting these percentages and prevalence ratios, we couldn't make any direct comparisons between these three groups. And there were many reasons for that, but some of the biggest reasons was because there was a lack of standardization among the different ways that these institutions collected data. There's also lack of a streamlined method. Everybody used their own method for data collection, which is normal, but it just made it difficult for us to make any sort of direct comparisons. So at the end of the day, we made snapshots. So we were able to collect this data and pinpoint, okay, what's going on respectively among these different groups so that we can understand these oral health outcomes and then generate new hypotheses and projects for future projects within Southern Plains. So with this project, we were able to increase internally data collection, which was one of the biggest things we wanted to do as well. And one of the other problems that we saw was that there was so much lack of race ethnicity data, and it was really difficult to come up with that because there was just a limitation on collecting that. So that did inspire us to work on projects where we are collecting data ourselves, which Alex is going to go into a little bit more next.
Thank you, Amanda. So the next project I'll be talking about is the Oral Health Survey among American Indian, Alaska Native, and general populations of Oklahoma. So this was the first data collection that we initiated at the Southern Plains Tribal Health Board. So this survey was also funded by the National Indian Health Board's Dental Therapy Education Outreach Grant. This is a community-based survey, consumer-based survey, and it was a cross-sectional survey to assess the barriers, challenges, and opportunities for oral health in Oklahoma among both the American Indian and Alaska Native general populations. So with this survey, we actually generated quantitative and qualitative data. So what you're seeing right now is our quantitative data that we collected. So we had 201 responses, which is really great. We had a lot of representation of like occupation. So this wasn't solely oral health professionals or public health professionals. This was a truly consumer-based survey. So we got a lot of connection with community members. I wanted to highlight the top 3 oral health concerns that we found. So we found that oral health services in rural populations, lack of covered benefits for oral health services, and also decreasing oral health related ER and urgent care visits were some of the top concerns. And in the qualitative section, we'll see a little bit more about that too. But yeah, we did a report with the qualitative results. These were results from open-ended questions on the survey to really get an idea of the attitudes and what the community members were really concerned about in their communities in terms of oral health. So we found major themes being community concerns and solutions. So some of the major findings we found was there was a need for more education on oral health and the role of dental therapists. Though we did find in the quantitative portion that a lot of community members were willing to receive care from dental therapists, there is still a need to educate more on what their roles are. There's also a lack of specialty services due to workforce shortages and lack of access, whether that be physical or financial. And then we also found some participants suggested family or general practitioners being trained in basic oral health services to increase access. And then the next project, I will hand it back over to Julie.
Okay, yes, thank you, Alex and Amanda. So the next project we're going to talk about is the oral health policy and improvement strategies in Oklahoma. And so this was actually a policy brief that we published actually, I believe the end of last year. I think it was September, October, November of last year. And this is the first policy brief that that we were able to do and publish and promote and stuff. So we're really excited about this, and hopefully it's the first of many. But this was through a partnership with the National Indian Health Board. And so through this partnership, we were able to work with the Director of Public Policy from the Oklahoma City Indian Clinic, which is an urban Indian facility here in Oklahoma. And so hopefully, I think we've roped her in. So I think she's like here to stay. So we're super excited because she's fantastic and great to work with, and a wealth of knowledge of policy and tribal policy. And so I co-authored this policy brief with her. And so what this includes is essentially an overview of the most recent publicly available demographic and oral health data for Oklahoma. But what we did is we included policy suggestions, implications, and barriers, but we stratified those by financial barriers and solutions, physical and workforce. And then we took it one step further and also looked at solutions in really kind of the tribal realm and the tribal area, federal at the national level, and then in state solutions and state barriers. So again, we're really excited about this publication and the work. And again, hopefully it's just a first of many. We're currently submitting this as a manuscript for publication, and we actually just found out a couple of days ago that we were published in a journal. So we're super excited about that. And this is also going to be used as a catalyst for hopefully a budding relationship and partnership with the Oklahoma Policy Institute. And so this is initiating some conversations and discussions and meetings about using this to kind of use their platform for discussions and hopefully action in something that will kind of build. Okay, and now next we're going to hand this over to Amanda for our next one.
Yes, so this next project is one that it's ongoing right now. So we are in the initial findings of the project, but I do want to talk to everybody about it. So we are conducting a systematic literature review, and it is focusing on the oral health workforce representing and also serving American Indian and Alaska Native communities. We do know it's quite common that American Indian and Alaska Natives are not proportionally represented in the oral health workforce, but we wanted to understand why and what barriers and even facilitators to the job contributes to this. So we're conducting this systematic literature review, which means we are pulling together all published literature on this topic, and then we're analyzing it. And we are analyzing this qualitatively because we want to understand this in the terms of clinical and public health relevance. And we also want to understand the cultural implications of an expanded workforce and also a diversified workforce. Next slide. Here, I just wanted to show the inclusion of articles for our systematic literature review. So we had a set of keywords that we put into a couple of electronic databases, and then it shows us all the different articles that may fit based on these keywords. So we did generate about over 350 articles, and from there we decide which articles we want to include for full text analysis and which ones we will exclude based on our criteria. So we did have the criteria that we did not want articles that were not US based. If they were a repeated article, we weren't going to include it again. We only wanted observational studies. We found that that was the most relevant type of study to our research question. So we did not include case reports or even randomized controlled trials. And we only wanted articles that included currently practicing workforces and if it was published before the year 2000. So based on looking at the abstracts, we did exclude about 320 and we included 35. Then we looked at the entire text of those 35 articles, and for similar reasons, we excluded 23. So we do end up with a total of 4 articles for our actual analysis. Next slide. So here are some initial findings because we're still going through analysis of these articles, but we did find that Alaskan communities utilize expanded workforce positions a bit more than communities in the lower 48 states. And this does include a dental health aid therapist. And we do know, though, that Alaska did start this type of expanded workforce positioning. So it does make sense that it's a bit more common in Alaska compared to other communities, but we do know that policy is changing throughout the US to allow for this expanded workforce in different communities. And we did also find a really positive finding that the expanded oral health positions aid in community members receiving more routine access care. And also this is an upstream approach because it is diversifying the dental workforce. We're seeing that community members are being part of these positions, which is helping with mistrust and also helping aid in any sort of cultural barriers that community members may have faced. And then one article did find that looking at American Indian and Alaska Native dentists only represented about 0.2% of all dentists across the US divisions. And the other thing I want to point out is that that data is from 2012, which is a little bit old, but that was the most recent data that we could find. So it is showing that we need to be able to find more recent data on this, and groups and communities need to be able to look at that as well. So future research has shown that we need to investigate more the pathway to these positions. How are we going to help engage community members in getting into these types of positions? Because it does help with community members serving as healers and important parts of routine oral health care. Thank you.
Thanks, Amanda. And I want to clarify. So the dental health aid therapist is essentially the same as dental therapist or dental therapy. It's termed dental health aid therapist or DHATS under the federal program, which is the Alaska CHAP program, which is CHAP stands for Community Health Aid Program, which again originated in Alaska, but is now expanding to the lower 48 states. So I just wanted to provide that clarification. Okay. And so just kind of in closing and wrapping up, I wanted to mention just a couple of other noteworthy projects. First being the Southern Plains Tribal Health Board administers a tribal version of the BRFIS survey. And we've been doing this for several years. And I started back in 2016. I was the lone oral health person. And so I'm really proud that that since then we've been able to increase our oral health data collection. So I believe there were maybe like 1 or 2 questions, oral health questions on that survey, and now I think we're now up to 7 or 8, and I think it's about 100 question survey, if I remember correctly. But so we've been able to increase our data collection, primary data collection through that survey, and we'll have a report hopefully soon. I'm thinking summer or early fall, hopefully. Alex, correct me if I'm wrong on that, but so I'm really excited about that, and hopefully we'll continue to build on that. And then the other thing I wanted to mention is through Open, NOHN has been able to participate through a CMS work group meetings, or a CMS work group. And so this has really been valuable in starting conversations about the availability of American Indian Alaska Native oral health data. And so kind of the next steps with that is we're now going to be meeting and having conversations with the CMS Division of Tribal Affairs. And at this point, we're really just trying to understand how these data are collected, how they're reported, and how we can how we can get American Indian, Alaska Natives better represented in this data. And so, what happens is when, the work and any progress that we make towards health equity is really stalled when American Indians and Alaska Natives, when we're consistently deemed statistically insignificant and we're lumped in other categories, or we're othered. And so, it's our responsibility as a tribal epidemiology center to make sure that we're collecting these data. And so, these projects, these things that we're doing and that we're building on, it's increasing our internal capacity to collect and report data, and it's a small step in the right direction, small steps. But really the bigger picture and the bigger conversations that are happening is the decolonization of data and these data systems. So American Indian and Alaska Natives are appropriately represented. And it's really what our team is focused on, and I know many other tribal organizations are also working towards. So thank you all for your attention. Thank you, Open, for giving us this platform and letting us to talk through open data stories. So thanks.
Well, thank you so much. This was just off the chart awesome. I don't know if that's correct language or not, but I'm saying it anyway. It was just fantastic. So I had written down several questions. The chat box was just really on a roll. And I think all of the questions that was in the chat box was answered. And plus, I think we also post this on Open Communities. But anyway, the questions that I had really were answered, especially when you mentioned in the beginning about data without action, how you need action. And then you answer that in your major findings, and in so many other ways you answer that. But I just wanted to open this up a little bit for a few minutes to those out there, because I began to see so many connections with some of the things that Open is proposing, that the NOHN is proposing, and especially as we look at bringing care to communities and how some of this data might be used in identifying communities in need, or that could benefit from some of the things that we're proposing. Does anybody out there have any questions other than what was, I think, asked and answered in the chat box regarding links and what have you? Are there any questions? And there's enough of, or a few of us on the phone that, or on the call, that we can just ask our questions. You don't have to put it in the chat.
I'd like to get a little bit more information on what you found as being impediments to having more providers that are Native American, or more dental therapists available to serve the population.
I can start, and then maybe Julie can chime in afterwards. So when looking at the literature review that we're working on, two major barriers we had found was burnout and stress, because a lot of times people in these positions are seeing a lot of patients, so it can become there can be a lot of time constraints when it comes to these types of positions. So we need to get more people into these positions so that routine access care is a lot more widely available. That was one of the major findings that we have seen so far. Like I said, it is preliminary, so we do need to go through the data a little bit more. Another thing that we were also looking at too was urban versus rural settings too. So how easy is it to get for community members to get to these facilities in order to receive services?
Yeah, and I'll add on to that too. In terms of dental therapy, we're doing a lot of work on that, and we're creating a dental therapy toolkit. It's with an Oklahoma focus, just because it has Oklahoma data in it, but it answers a lot of those questions, and we're hoping to have it done Alex, May or June, and have that available. But in terms of getting providers right now, I mean, there's a lot of policy barriers. So even though it's a federal program, the Indian Healthcare Improvement Act, which I believe was early 2000s, there was language inserted in that piece of legislation that said, even though this is a federal program and tribes have a sovereign right to serve the community how they see fit, that there was language inserted that dental therapists, just this provider, had to be approved by state legislature. So that poses a lot of the barriers in getting providers, because we have to go through that process. And so, and this, again, as a reminder, this is through, again, the federal program CHAP, which is the Community Health Aid Program. And so as this is rolling out into the lower 48 states, there are other providers under this program, and it's essentially divided into 3 disciplines: behavioral health, primary care, and oral health. And dental therapy is the only provider out of all of it, and mind you, all 3 providers have various scopes. So you have kind of like an entry level provider, and then you get into a wider scope. And so dental therapy, which is obviously a wider scope of practice, is the only provider underneath this CHAP program that requires state legislation. So that is that's one of the main barriers. But we'll definitely get more information out about that once we get this toolkit completed.
Well, thank you so much. And there's someone asking a question. Oh, it was answered by contacting you guys. Fantastic. Are there any more questions last minute? Again, if there are no other questions, I just really want to thank the 3 of you again so very much for this incredibly informative presentation. And we look forward to hearing from you again, or with a follow-up. So thank you again. Francis, you have anything to add to that? Or
No,
Ife, I think we've heard from
we'll
you.
have the recording posted. I saw that people were asking for slides, so we'll make sure that those are also posted and shared out. And we hope to see you next time. Thank you all so much for joining us.
Fantastic. Thank you. Bye.
Thanks, everyone.
Thank you for having us.
Thank you. Thanks for having us. Appreciate it. Good to see you guys.
You
Great.
too.
Thank you.